So as Adam said, I'm going to be talking to you about the work we've been doing in clinical workflows using EHR data. So just give you some acknowledgements about the funding, financial disclosures. I have none. One of my colleagues does. But then we'll get to why we're actually here. And talking to many of you this morning, we're all sort of grappling with a lot of the same issues. Looking at clinical workflows, figuring out how this EHR that we're all dependent on has become such an integral part of the practice of medicine, how it's affecting everything we do, and what can we do to improve workflows using data from it, but also how can we improve the use of it as well. So I'm going to talk to you today about the work that we've been doing at OHSU, and I work at the KCI Institute, which is the Department of Ophthalmology there at OHSU, and it's one of the major tertiary referral centers in the U.S. for eye care, has a lot of annual encounters, and probably the thing that's the most distinctive about it is that it has a dedicated informatics research center. And so that group is led by myself and my partner in crime, Dr. Michael Chang. Some of you know him as well. I bring the computer data science operations research aspect to it. He brings the clinical side, but he's also an informatician, so we speak the same language. We have a rotating set of people that come in and out, and we have the benefit of working with med students, postdocs, from informatics, but also from the medical school as well. But probably the most valuable part of our team is the analyst who gives us all of our data, and he works full-time for us. So at KCI Institute, we were challenged with how can we improve clinic efficiency, and how can we do it in a way where we're partnering with the clinical staff. And obviously, this is going to be motivated by financial and increasing volumes and things like that. But we also know that wait time can really become a barrier to care. We find that first of all, it's a real big driver of patient satisfaction, but it's also they found in ophthalmology in particular when there's these really large wait times, which are unfortunately very common in clinics. They can wait 3 to 4 hours. People just don't come back for their care. So we really need to figure out how to improve this. So that's what I'm going to talk to you today about, and talk basically 2 parts. So the first part is, what we've done in kind of clinic operations to tackle this. And this is the work that I've been working on the longest, most mature, has results. Actually, we've done some implementations of things in clinic. And the second one is sort of what I call the elephant in the room, where we're working and embedded with these clinicians, trying to help them make their clinics more efficient. But really, what we keep hearing is, if you really want to make my life easier, can you make the EHR better for me? So I'll present some of the work that we've started trying to tackle this problem using data from the EHR, but it's still very much open-ended and trying to figure out where we're going to go from here and how we're going to do this. So getting started, we looked at, when we started looking at our clinic operations, the first things we did was we just got into the clinic and wanted to see what was going on, observed, timed the clinic workflows to be, okay. Does it need to be? Yeah. Okay, all right. So, it's trying to figure out where we're starting from, but also get some sort of gold standard data for validation. Then we looked to the EHR to see, what timing data can we get from the EHR that kind of maps these workflows, so we can look at these timings and workflow on a much larger scale than we could ever observe. And then once we validated that data, we're able to build simulation models looking at, okay, so this is what the clinic looks like. What happens if we change this or change that? We validated both the data and the models, and then we actually developed some new scheduling templates and implemented them in clinic, and then evaluated their impact. So just to start off, this is the very basic clinic workflow. We started easy with the clinics that had this workflow. We're now looking at much more complex workflows, but this is the basic one to begin with, and it's not all that different from what you might see in other specialties, where the patient comes in, checks in weights. Then an ancillary staff member, in case of ophthalmology, is going to be an orthoptist or a tech, does an initial part of the exam. And then the patient, in ophthalmology at least, may or may not be dilated. If they're dilated, they're sent back to the waiting room for about 20 minutes. They come back to the exam room, and then they're going to see the physician, and then they'll go home after that. So there are two main spots where they can generate weighting, and that's for both pieces of the exam, for the ancillary staff or for the provider. So we really needed timings for each steps of this so that we can actually figure out how and when patients are waiting. So we looked to our EHR, and at OHSU we use Epic and have used Epic since 2006. So we were able to get a lot of data from there. So the check-in and check-out times are available from just the basic visit data, or they should be. Unfortunately, depending on the clinic, we can have up to 10 to 20% of visits missing the checkout time. So we've had to do some magic trying to come up with surrogate timestamps. Sometimes the after-visit summary works well. Other times we just try and figure out the last kind of contact time in the EHR that we used for a surrogate. And then we can also, from our ophthalmology visit data mart, figure out if they were dilated or not. But then those exam times, there really wasn't anything in there, so we had to kind of come up with our own, and this is where we use the audit logs. So we use a lot of contextual data to try and figure this out. So we're able to kind of, and I'll talk about that here, is we're able to kind of bound when we're looking for, because we know when the patient checked in and checked out, or have at least an idea that then in that time frame, we know the user IDs for staff and providers, we look for those user IDs. And we also are lucky, at least from our perspective, that we still have dedicated workstations within exam rooms. So we can look for those workstation IDs to know, okay, they were in an exam room with a patient. We can figure out when the first time was, when the last time was, and kind of calculate that difference. And then from that, we can calculate their wait time. If we know the total time we're there, they know the contact time, and if they were dilated, we can then calculate that wait time. So we're able to validate this, and for most appointments, I think 85 to 90% of the appointments, we were well within 3 minutes of the actual total contact time of the provider and the staff member. But on average, the mean was we were within 0 to 1 minute. So we got pretty good data. But you can see or look at these density plots that it doesn't always directly overlap. A lot of times we can underestimate the time using EHR timestamps if the provider didn't reliably start using the EHR at the beginning of the exam and do something in the EHR at the end of the exam. So if there was any sort of talking that went on at the ends, we might have missed that time. The other, we can overestimate time as well, because sometimes staff or providers will stay in the exam room and continue to document after the patient has left. So sometimes for some providers we were overestimating a bit. But for the most part, for our intents and purposes, it was pretty good, and it allowed us to get thousands of data about thousands of appointments. So from that, we're able to generate these simulation models, and we use discrete event simulation, which is basically like generating, it's almost like a flow chart of what the workflow is, and then for each step in that, we can have timings, and we can have what resources they need. And the timings, and what makes this a better fit than using just an average, is we actually generate a distribution for like each time step. So like the initial exam, we generate a distribution from. So then every time we run that simulation model, we have, our sample patient goes through, we sample a time, for the arrival, for the initial exam, for the provider exam. And then we do this over, thousands of exams and clinic sessions, so we can get a general sense of, how something might be impacted over time if we make different changes. We did model this for 4 different ophthalmology clinics in different subspecialties. I'm just going to show one for simplicity because they all essentially follow the same pattern. And I'm going to be showing the pediatric ophthalmology clinic. So one of the first questions that everyone asked, at least from the staff member, the clinic manager perspective, was, we want to reduce patient wait time, so let's just throw more staff and more exam rooms at this. And it was really nice being able to show through a simulation model that this really wasn't the answer to their problems, because we saw that, yes, increasing a staff member from 1 to 2 got you a lot of decrease in patient wait time. Same thing with the exam room. But once you had 2 staff or 2 to 3 exam rooms, it really wasn't going to impact your wait time anymore. And the reason for that is that at that point, they aren't the bottleneck. It's the provider that's the bottleneck. So we have to do something better to address that. So we look to scheduling. So I think most of you who have outpatient clinics recognize that there's this sort of pattern where you have busy times and slow times, and the providers would complain that, yeah, I have 5 patients here, but they're all either being seen by staff members or they're in the waiting room being dilated. I have nothing to do for the next 20 minutes, and then in 20 minutes, I'm going to have 4 patients ready for me at the same time. So how do we kind of make this more of a steady stream of patients throughout the day? And there's a lot of literature out there that's been done in operations research that suggests that when we schedule patients according to what their expected time is, or even their variability, we can really decrease average wait times. So what we did in the simulation model was we looked and we saw, well, let's identify some really long exam times or long encounters and see what happens when we put them, at various stages of the clinic session. So along the x-axis is sort of the position in the schedule. So position 1 would be the first appointment of the day, and position 13 would be the end. So what happens when we start moving these more towards the end of the day? And yes, which is the blue line represents the average wait time. As predicted by the literature, we actually decrease wait time when we put those closer to the end of the day. The clinic managers, however, had not been doing that. They'd been putting them at the beginning of the day because they didn't want the clinic to run late, which is also an important consideration. So if we map how long the clinic takes, which is the orange line, you can see that yes, as you put them closer to the end of the day, you do kind of on average increase your the length of your clinic. I will say, however, that impact is not as much as a simulation model may suggest, because we really didn't do the real detailed scheduling or the detailed piece of our model that would account for that. So our model is kind of just blind. It doesn't care if it's the middle of the day or the end of the day, it's got the same distributions. In real life, though, we know that staff members and providers will attend, if they know they have a lot of patients waiting near the end of the day, will speed up a little bit. So it's probably not going to be as bad as this suggests. But it does tell us that maybe we don't want to put the long encounters at the very end, but maybe if we put them close to the end, that's a good solution. So we came up with this new template. We worked with the providers to come up with this. And we actually divided the patients into 3 groups, short, medium, and long, as opposed to just long and not long. And we scheduled the short ones at the very beginning of the day, and then the mediums kind of in the middle, the longs towards the end, but not at the very end. And then we went back to mediums, but a lot of times at the end we can put shorts in there as well, just as long as they aren't, going to extend clinic too long. Then they also asked, well, we'd really like to have, what would happen if we put a catch-up block in there where we don't put any patient at all? So we ran simulation models and determined the best place to put that was kind of in the middle of the long block. Now, I will say that in practice, that empty space never is there. So what it's really become a placeholder for is urgence. But at least now there's a place for it to be put as opposed to being double booked. And it really does work out. We use simulation models to show that actually does work better than double booking another slot. So we implemented this in all the ophthalmology clinics, but this also requires that we are able to, at the time of scheduling, figure out what slot a patient belongs to, which is not always a simple task. So we worked with the ophthalmologists and with our data to come up with some guidelines. So we know, for example, that new patients always take longer than return patients. Adult patients take longer than child patients. And you're probably thinking in a pediatric clinic, why would they be seeing adults? But in ophthalmology, pediatric ophthalmologists are the ones who do strabismus. So you're going to see adult strabismus patients as well. So we know that just from those rules, but then we also relied on the provider follow-up. So in their follow-up note, they would mark what they thought the next appointment should be. Should it be a short, medium, or long? So that's what we were using. We've also, and I'll talk about this in a minute, have done some machine learning models that have tried to predict where patients fall. So when we implemented this, we implemented it in a staged fashion. We implemented it in our first kind of partner clinic, the one that we modeled, and we got really great results. We got that their wait times were decreasing on average, and this was at a time we actually were doing this in conjunction with the entire department of ophthalmology trying to get patient volumes up. So it was sort of like, okay, so if we know we have to increase volume, what are the things we could do that try and make that less impactful? So the templates that we were creating automatically were including more patients because that was part of the whole process, even though that wasn't really part of what we studied. And so at this time, even though they increased their volumes, they still were decreasing their average patient wait times. And then we implemented it in the remainder of the 4 pediatric provider clinics, and they all increased their clinic volumes. So the decrease in wait time just was really dependent on how much they increased their clinic volumes, because some of them actually, the one that the wait time eerily stayed exactly the same, she increased her average clinic volume by 3 or 4 patients. So that was a pretty good impact, and this has actually been written up. But we still, the scheduling is hard, and part of what was in the paper that I don't normally talk about is, adhering to that schedule, because a lot of times you'll have patients that, can only come in at a certain time. So what do you do? And so we try and minimize that as much as we can, and a lot of that went down to education. So we actually showed the schedulers, we had a meeting, we showed them, like, when you follow the template, look how much you've reduced the wait time versus when it's not followed. So they really felt like they were part of this and like, I can do this and we can really get this going. But the other thing is that how well are we actually predicting where, even if we schedule perfectly, how do we get those patients in the right slots? So we started seeing, can we do better than what we're currently doing, and let's use machine learning. The other thing I'm going to talk about a little bit is how trainees, in fact, impacted this as well. So for the machine learning, we used a lot of different features. The ones that turned out to be the most important were patient age, the diagnosis, the average of their previous exam times, the type of visit, and whether or not they were dilated. And this is interesting because this kind of mimics what we were using as part of our ad hoc algorithm as well. And the results were that we were getting actually much better accuracy from our machine learning classification than we were for our provider prediction. Now there is a caveat to this, because we are going off of the actual visit. So when we timed the actual visit, then where would that have fallen? And there's a little bit of a problem doing this exactly. So for example, you might have truly had a short patient, but because you're at the beginning of the day and you didn't have anyone waiting for you, you may have taken longer with that patient than you would have otherwise. So these may or may not be, and we're still trying to figure out how do we evaluate this in a way that kind of takes all that into consideration. But we're actually doing a lot of work trying to improve this prediction. And then the other thing was we wanted to look at trainees. And when we originally did all this analysis in our simulation, we deliberately kind of left trainees out of the mix just because we knew they were a little bit variable, and we wanted to see, just for the general case, how this worked. So we went back and we looked at data about 50,000 appointments, and these was KCI. And we found that, about a quarter of them used appointments with a trainee, and this is really variable in terms of subspecialties. Some specialties, all of their appointments have trainees, and some specialties really have very minimal. And we built different models to try and characterize what was going on. So just as a general kind of ophthalmology-wide perspective, we found that residents added about 17 minutes to the exam time, and fellows added about 13.5 minutes. But one of the most interesting results from this was that not only the patients or the appointments that were with the trainees were lengthened, but if a trainee was actually in clinic that day, all the other patients' appointments were lengthened as well. And that's because then the provider becomes more of a bottleneck on those days. And the effect of it is really variable depending on the clinic and depending on what type of visit you had. And we've done some work and published some work about when it matters and when it doesn't matter. But it's, on the average, can be up to about 15 minutes. So when we started thinking about this, how this is impacting our scheduling template, this kind of came to a head this summer because we had a bunch of trainees in our pediatric clinic where they had just implemented this new template, and all of a sudden they were running over into lunch and running over at the end of the day. And they had a bunch of orthoptist students in there, that's the ancillary staff, in addition to the normal residents and fellows. And they were all starting with the patients at the very beginning of the day. So we were getting complaints from the providers that not only were they running over, but the providers weren't busy. They wouldn't even see their first patient for at least an hour into the clinic because they were spending all these time with students. So we started analyzing the data, going back. This is sort of an ongoing kind of internal QI thing that we're not necessarily publishing, but I thought it'd be interesting to talk about because we can build this great schedule from the patient perspective, but we have to be thinking about what we're doing in the clinic. So we made this rule that trainees no longer see patients in the first 30 minutes in the clinic so we can get the provider busy and get them in there. And we also started staggering when students start so they're not all taking patients at the same time. And so we have very preliminary results. I mean, this is really like within the last 2 weeks we started looking at this data, and it seems like we are decreasing the clinic length. So we're running less into lunch and less overtime. And physicians, when we measure their idle time, have a lot less idle time and are getting busier sooner in the clinic. So it's kind of important that we're looking at everything that's going on in the workflow. So that brings us to the second part of what we've been looking at, which is just looking at how are the EHRs being used, how are they impacting efficiency for providers, and really just what are they doing. And so, in the time that we were embedded in clinics and talking with physicians, as you might imagine, a big topic of conversation was, this EHR is really getting in my way. It's time consuming. And so what can you guys do about this? And I'm like, well, I don't know if we can do anything about it, but we can look at our data and at least confirm that you guys are right. And so we started measuring things. And so we use different types of EHR data, some of it audit logs, some other things, to try and figure out what they're actually doing. So this is just a basic overview of how we calculated physician EHR use. And we are using the general access logs from Epic that just record a timestamp for when you open essentially each window. So we're not doing the mouse click or the keyboard stuff. And so when we calculate the EHR use, we calculate essentially the number of minutes that a physician has some audit log activity. And so it's not perfect. It could underestimate if you were doing something that didn't take a full minute, but that's rarer than or overestimate if it took under a minute. But most of the time we think it's underestimating. So for example, if you're writing a progress note, you open up the progress note, you could be typing for 10 or 15 minutes, you're not generating any other EHR activity, so we would miss that. But it's a best guess for where we're starting. So we looked at how much time they're using the EHR just in general. And so the average is that it's about 4.3 hours per day on average, and it does vary by subspecialty. And it's a mix of what we call patient care time and something that's not related to patient care. So essentially everything that has a patient identifier on it, an MRI on it, is considered part of that patient's care. But then there's a lot of entries that are just either navigating or looking at schedules that aren't attached to a particular patient, so they don't have that in there. So the majority of time that they're spending is, working on some sort of patient care, whether it's, writing up an encounter note or, it's responding to an in-basket message or something like that. So this is something that, is taking a lot of time. And we also want to look at how has this changed over time. So we went back and we looked at the same timestamps over the past 10 years since Epic has gone live at OHSU, and this is the average amount of time per encounter, and you can kind of see that it's increased over time. And we kind of mapped out, it's kind of hard to read here, but the different stages of meaningful use and where those came in. And so when we showed this to our Epic analyst, he was like, oh, this is awesome because it shows, meaningful use kicked in. Look at now providers are really using the EHR. And his perspective is that he was part of the initial, build of Epic and getting people to use it and all the frustrations that went on with that. And so he was like, okay, meaningful use did its job. Obviously, you show this to physicians, and they're not saying yay. So what we're trying to figure out is, first of all, why has this changed over time? Is it actually, in fact, decreasing now? Are we on a decreasing trend? Is it stabilizing? If so, why? Is it because people are becoming more proficient with it? Are they using more of the templating or the shortcutting things? We don't know. So we're still looking at this, but we think it's kind of telling us a story and helping us figure out where we want to go from here. We also know that a fair amount of time that's spent on the EHR is reviewing things. And so we wanted to see, can we find out from the EHR what people are looking at? And the answer is yes and no. We can figure out when they've read an entire progress note, and we can count those. We can't figure out very well. There's records of it in the EHR, but they're so nonspecific. We don't know if you're clicking on different pieces, like in different flow sheets and looking at past. It generates this. It was for this patient. You don't know what encounter it was. You don't know what part of the chart it was. You just get this generic report with patient data viewed. So we can't get a perfect look, but we can look at what you've reviewed progress note-wise. So we counted the unique progress notes that were accessed or prior ones in the audit log during an office visit. And we found that on average, physicians were looking at about one prior note per visit, which is through informal discussions with some of our ophthalmologists, they confirmed. We found that staff reviewed more. And from what we heard is that was because in a lot of clinics, what the staff would be doing is when they first saw the patient was they would start the template for the note. They would be opening up the prior notes, copying relevant pieces into that progress note, so then the provider didn't necessarily have to look as much other types of notes, whether they be progress notes or different kinds of results. And then we also looked at what were the average number of notes that were reviewed versus the progress notes versus the other types of notes. So the orange bars are, if it was an actual office progress visit, the other ones were other notes. So it could be, looking at a result or something like that, a report. And different specialties are going to be variable. Obviously, like something like neuro-ophthalmology is going to be very reliant on other types of notes other than progress notes. And then other ones aren't so much. But overall, we found that they were looking at essentially about 1.5 office notes and other types of notes. And the reason that this looks a little bit different than provider versus staff is that this is unique. So it could be that the provider and staff are looking at the same notes, so they get counted a little bit differently. But this is about 3 notes per visit are reviewed in total, and there's going to be differences among the specialties. So then what does this mean, and how do we go forward? And we're still not sure, and I've talked with some of you today about this. It's a difficult thing trying to figure out not only what are people currently doing, but how can we make it better? And so we're trying to use the audit log data, not necessarily to answer all the questions, but maybe to motivate the right questions or motivate the right studies that we have to do, either qualitatively or using other types of data. So one of the things that we started doing was looking at progress notes and figuring out, how much of the notes are being generated by templates and copying versus manually entering, how similar are notes, and the numbers are high. I mean, our ophthalmology notes are on average about 80% imported, whether it's copied or templated. And we actually just finished last week at looking at it broadly for hundreds of thousands of visits, and that's really the number that's coming up. And about 75% of the notes remain the same between visits. And we're now looking at, and this is very preliminary data, if you have the same provider, same diagnosis, 2 different patients, how similar their notes are, and that is approaching 50%. So when these notes are so similar, are we able to really first of all, differentiate patients, but can we find the relevant data that's really new? And especially when these notes are long. Some of these notes are on the order of 4 to 6 pages long. So where do we find this? We know that we've done other analysis on, assessment and plan changes the most, but they're often at the end of the note. So how do we make this a little bit easier for providers? The other thing that we looked at over time was how this note length has changed. And this one we don't think has necessarily been impacted the same way by meaningful use. It probably has to some extent, but it's just sort of doing this increasing thing over time. And is this sustainable? And so what can we do to intervene to try and make this better? Not only for clinicians, but for patients as well. How can we improve their outcomes, and how can this relate and make better strides towards their care? So as all of you know, there's a lot of limitations to using this audit log data, and anyone that's looked at it has known that there are, especially if you're mapping anything like workflow to it, there's going to be gaps, especially if the provider wasn't using the EHR, so it's not perfect. The granularity of the timestamps is limited. All of you are using Epic. We've all, and Adam and Mark know this too, they're coming out with sort of a hybrid access log kind of tables that are sort of a mix of the sort of like low granularity, I clicked on the screen, combined with, okay, I did all these mouse click things to try and be able to estimate a little bit better that, okay, you opened the progress note and you spent this much time here, as opposed to just giving you a single timestamp. But it's still reliant, it's still not going to be perfect because it's going to involve some sort of aggregation and some sort of rules that Epic sets. It's also not complete because we have, at least in ophthalmology, they're accessing imaging, they're accessing all of these separate modules, and we don't have any audit log data for that, and we'd have to go to those and try and manage that as well. And we don't know if these methods are going to generalize outside of ophthalmology. We're now working on that with other departments at OHSU to see if we can get some results. So in summary, we've used the audit log data to study our clinic workflows, and we've reasonable success in modeling workflows, evaluating them, being able to make changes in the clinic, and then evaluate if the changes, what the impact of those changes are. And we're using them now to see if we can do some predictions with that. We are also using it to show or to look at, can we, sort of support physicians in their complaints about this and show that, yeah, this is taking a lot of time. Obviously, just showing it's taking a lot of time isn't necessarily pointing you at the right direction for improving that, but that is sort of one of the open-ended questions we're still looking at, is how can we use this data to really help direct us to make better changes and supports for physicians in the EHR. So, and this is sort of what sort of got ahead. So we're, going to be looking at more complex workflows, and then sort of look at more of these studies of documentation. And sorry, probably in too small a font is my email at the bottom there, if anyone is interested in contacting me. But that's sort of all I have to say for now. But I'd love to answer any questions or have any discussions with you about this topic, because I know a lot of you are doing similar things here, and love to hear your opinions and thoughts.